You want to do it in the other room? Okay.
Hello?
Hey, sorry about that. I am back, but I don't see the invite again.
Oh no.
No.
Oh my goodness. I'm so sorry. I don't know what happened. I think it's because I called on my email and it like didn't save to the YouTube.
Oh, no, you're fine. I totally get how there's those.
Okay,
Must
so
happen.
it says it's sending to you. I don't know what is going on.
Get
Okay,
my
so
Google.
it's BRETT dot 12
Mhm.
dot ROBINSON at gmail.com, right?
Yep, that's it. Let's refresh it just to.
Okay, I just sent it again. Anything come in?
No, I don't see anything.
Yeah.
Let's see. See my invites. Wait, hold up. It says that it's spam.
Oh, you're getting them through spam?
Yeah.
Oh my word. Probably
That's
because I was
why. Okay,
inviting
let's
you
see.
like 80 times.
Say that again.
Probably because I was inviting you so many times. They're like, up, spam.
Yeah. Okay, now, yeah, it's showing me, okay, you're about to join a Hangout on Air. Okay, got it. Okay, let's see. Seems like it hasn't loaded yet. Something.
Want me to resend it?
Well, it says, so what it's saying is, Carolyn Hanks is not in your circles. You're about to join a Hangout on Air.
And then it won't let you join because I'm not in your circle thing?
No, I don't know what that means. Hold on, let's see. I'm gonna do it one more time. Let's see. Okay. Yeah, I'm just gonna do add people. Okay, let's see. So I'm gonna go here. Okay, got it. Weird. Okay, hold on. Let me try this one more time. Okay, I added you as a contact.
Okay.
I'm going to accept and
I have to accept?
oh wait, now it looks like I'm trying to video call you. Oh dang it, I'm trying to call you.
Oh.
Can that work or no?
Yes.
Do you see that?
But then you'll have to be the one to turn in the video if that's okay.
You know, I don't know how to do that. Hold up. Yeah, can we try to call me one more time and then
Yeah, I'll
or
try.
invite me? Hold up. Let me see. It says, okay, hold up. It just said error. You're not allowed to join this video call.
Oh.
Okay, there we go. Okay, answer. Okay, I read and understand and agree to rules, and then join.
Haha. Okay, great. Sorry.
You did
Sweet.
Awesome. Okay, I'll hang up the phone here.
Okay. And hopefully this won't be too long since we already did it. Okay, so oh yeah, let me screen share. Oop, don't know what that is. Oh wow, looks really weird.
Wow.
All right, so I'll go ahead and start on it real quick.
Great.
All right, so this is our project. We're going to go ahead and start. We are doing malaria in Uganda, and our presentation is called Health Surveillance Program.
Awesome. Okay. All right. Hey, actually, would you mind? Oh, perfect. It looks like you got it to full screen there. Thank you. Okay. So first, we're going to talk about some of the needs for our project here. So this intervention presents evidence-based public health strategies put in place in order to protect pregnant Ugandan women and their newborns from malaria. This is a huge epidemic going on in Uganda, and we'll show some of the numbers, but this is what our project is all about. So mothers and babies that are affected by malaria have high chances of maternal anemia, placental parasitemia, fatal hypotrophy, preterm delivery, stillbirth, miscarriage, and low infant birth weight. According to the most recent data, which is in 2016, malaria is the third leading cause of death in Uganda and the second leading cause of premature death. This shouldn't be the case because, malaria is 1, preventable, and 2, treatable. So that's why I feel like this shouldn't be the case. We're working on it. Burden of malaria in Uganda is huge. In Uganda, the total economic loss was $658,200,558. If we increase the surveillance and funding of malaria and the education of how this surveillance can be effectively transmitted, this number will drastically increase for that dollar number for economic loss. So we've got a YouTube video here that will talk a little bit more about this problem.
More than 40% of the world's population is at risk of malaria, and the greatest burden is felt in sub-Saharan Africa. Among the most vulnerable are pregnant women who are susceptible to severe anemia, more likely to have underweight babies, and less likely to fight off the infection. The fact is, malaria in pregnancy accounts for as much as 10% of all maternal deaths in endemic areas. But malaria in pregnancy can be prevented by sleeping under an insecticide-treated bed net and regular dosings during the 2nd and 3rd trimester of pregnancy of 3 small tablets known as sulfadoxine pyrimethamine, or in short, SP. This dosing is intermittent preventive treatment in pregnancy, commonly known as IPT-SP. TIP-TOP is an ambitious project focused on transforming IPT for optimal pregnancy in 4 countries with moderate to high malaria transmission in Africa. IPTSP is a cost-effective, high-quality preventive intervention that we know works in almost every case. But only an estimated 31% of eligible pregnant women actually receive the recommended 3 or more doses of these 3 small tablets. TipTop is working with ministries of health in the Democratic Republic of Congo, Madagascar, Mozambique, and Nigeria to take every opportunity to get this highly effective preventive medicine to the most vulnerable women.
Awesome. Okay, and we'll turn it over to the next slide.
All right, so that video talked a little bit about the medication that we are going to focus on within our project here, as our target population is pregnant women, and the target medication that we are looking to kind of have a more steady supply chain of is ITPSP. So the WHO has recommended that every pregnant woman in areas of moderate to high transmission and in the second trimester of their pregnancy, these women should receive a full course of antimalarial medicine, regardless of whether or not they are infected with malaria at the time of their pregnancy. This antimalarial course requires that the woman should receive at least 3 doses of the vaccine of ITPSP during pregnancy, with each dose being given at least 1 month apart. So this therapy is the ITPSP, which stands for Intermittent Preventative Therapy, and it is proven to prevent malaria complications during pregnancy. This quote here says, "Patients continue to die of preventable diseases as a result of having an inadequate stock of medicine in public health facilities." So this is a major barrier of why malaria isn't eradicated in Uganda, is because we just don't have, or they just don't have, the medication that they need to prevent it. A 2015 report by the Budget Monitoring and Accountability Unit of Ministry of Finance shows that more than 90% of public health facilities reported non-supply of ordered medical items, including drugs and stationery. The status report showed that essential medications, including malarial medicines, along with many others, were not readily available to the people that need them most. And in this case, they're not readily available to the pregnant women.
All right. So among the approximately 840 million people that are at risk of malaria in endemic countries in sub-Saharan Africa, an estimated 35 million pregnant women could benefit from IPTPS each year. However, during the last few years, the WHO has observed a declining effort to scale up IPTP in a number of African countries. So again, as we were finding, when we got these results in 2012 of this vaccine, however, the numbers should be increasing. So that's what we're trying to work towards.
So kind of the problem here that we've discussed in the previous slides is just the lack of medication that the health facilities have. And so to come up with a solution to this lack of medication that the pregnant women have accessible, and to kind of also kind of help the lack of health personnel like nurses and doctors, our program that we've come up with will put into place a health surveillance system. So according to the WHO, a public health surveillance system is a continuous, systematic collection, analysis, and interpretation of health-related data needed for the planning, implementation, and evaluation of public health practice. So our program will use a passive surveillance system. And a passive surveillance system is the routine reporting of health data, including a routine reporting of medicine shortages, which is very important for these women, and for health centers across Uganda, to healthcare officials. In this case, it will be these findings will be reported to the WHO. So the good thing about this type of surveillance, about the passive surveillance system, is that it is low cost, which overcomes a money barrier, which for countries in sub-Saharan Africa that may not be able to afford kind of a rich, fancy program, this could definitely be an answer. So our intervention requires every health center in Uganda to report to the WHO every 2 months to let them know 3 things. So the first thing is the needs of the health center staff. So what health personnel do these health centers not have? Second, the number of women currently taking ISP/SP. So how many people are able to receive the medication that they need at this time? And third, the number of women currently pregnant. So there we can compare, the number of pregnant women that are taking the medication and the number of women that are currently pregnant, and then the health center staff. The WHO can then, from this information, understand the areas where ISP/SP intake is low among pregnant women, and they'll understand why as we look at the health center staff and maybe the shortages there and the medicine shortage there. And they can then have a better idea and decide how to further help. As this surveillance practice is put into place, healthcare officials will be able to find malaria among pregnant women in sub-Saharan Africa and make sure they have all the resources available to them. They can kind of fix the supply chain of these medicines to the health centers and decrease the amount of women contracting the disease. This will therefore decrease malaria mortality and morbidity among pregnant women and their infants because they are able to receive the antimalarial drugs that they need to prevent this disease.
Exactly. Well, so again, our goals include increasing the number of pregnant women taking IPT at PSP, and then increasing the healthcare workers in the facilities, and then increasing the use of IPT PSP among other medicines by making them available. And this, again, some of these things are just increasing the education within these hospitals and within these facilities. By these simple things. I work in a hospital, and I know that this communication is much easier said than done. But as we are increasing in these small steps and reporting accurately and often, these healthcare facilities will be able to understand and learn and be able to already start to solve some of these problems themselves as they begin to do this. So we're going to watch a video that talks about some pretty lofty goals that have been set by the WHO.
Over the past years, there has been a dramatic decline in the global burden of malaria. Progress includes a 37% drop in new malaria cases, a 60% drop in malaria deaths, and a 65% drop in deaths among children under 5. 10 countries that had malaria in 2000 are now malaria-free. Nearly 60 countries have reduced their malaria cases by 75% or more. The malaria target of the Millennium Development Goals has been achieved. Progress was made possible through a massive scale-up in effective malaria control tools. Mosquito nets have protected millions from infection, illness, and death. Rapid diagnostic testing has enabled timely and appropriate treatment. And every day, artemisinin-based combination therapies save lives. But our journey is far from over. In 2015 alone, more than 400,000 people died of malaria. And there were 214 million new cases of the disease. Across Africa, 1 in 4 children is still not protected by mosquito nets or indoor residual spraying. And about half of pregnant women at risk of malaria do not receive a single dose of preventative treatment. Malaria is preventable, and it is treatable. To accelerate action towards elimination, the World Health Assembly has approved a global technical strategy for malaria. The strategy shares the same timeline as the Sustainable Development Goals. It sets ambitious but achievable goals for 2030, reducing malaria cases by at least 90%, reducing malaria deaths by at least 90%, eliminating malaria in at least 35 countries, and preventing a resurgence of malaria in all countries that are malaria-free. To achieve these goals, global financing for malaria will need to triple from current levels, reaching $8.7 billion annually by 2030. With all partners united, we can defeat malaria and transform the health and livelihood of millions of people around the world.
Awesome. So we can talk here how their goal is to reduce the effect of malaria on pregnant women by 90%. This, that sounds amazing, and I think that it's very doable. But, as we are implementing these processes, as we're increasing the number of people that are pregnant women, that are taking IPT, PSP, and increasing the healthcare workers in the facilities, making these medicines more readily available, we're going to be able to reach these goals as we're really starting to implement this. Yeah, so I think that's it.
So just to talk a little bit about some of the barriers that may be seen within our implementation here. So in a recent study by a doctor, he performed the study in a sub-Saharan African country, not necessarily Uganda, but it was shown that only 30.2% of the 6,549 pregnant women that he studied took the recommended 3 or more IPT PSP doses. And, why is this? And so 2 of the barriers to these women not taking the recommended amount of the antimalarial drug is a shortage of staff, kind of that we talked about, and that the medicine is simply not available. So one of the ways to overcome this, as was shown in the video, so our program will ask for an increase in health center funding from the government. So that is a big barrier that needs to be overcome, is the funding of the malaria projects here. That if we have more money to put towards these implementations, we will be more fully able to give out the medications, to have more technology and things of that nature to prevent malaria. So this is a huge barrier in effective surveillance, but can be overcome as this program works with Ugandan public leaders and helps them more fully understand the need for more funding. Other barriers that other people may have when trying to implement our project may be a lack of computer equipment and electronic medical records. And again, as funding is increased, these barriers can be overcome and more technology can be provided. So IPTSP is only one of many services provided at antenatal clinics, and a lack of staff may lead to some services being overlooked. Sometimes the recommended medicine is simply not available, just as mentioned before, but hopefully we will be able to, with our surveillance program, decrease these effects and increase the supply of medication given to these women. As stated by the WHO, when you have a good health system, you have good malaria control. And just to finish up here, Yolanda couldn't be with us during our presentation tonight, but she did send in a video clip, and so we're going to go ahead and finish up with that.
Hello, my name is Yolanda Guedes, and today I will be talking about the barrier that we found in our intervention. And some of the barrier that I could find was that I know there's a shortage of medical staff. It's everywhere, so which may affect the way the medicine is being provided, and also there's not enough staff, there's not enough medical professions specialized in just women care, so which can be an issue. And another one was I found that was not a lot of people have access to healthcare, so not everybody can pay for those for the medication, even though I know it's not expensive. From the research that I have done, it say that it only costs 12 cents per dose, and which is a total of 50 cents for all the 4 doses that you will be taking. But it's still too many people, and they may not have that kind of money to spend on medicine. And I also found that a lot of the supply, they will run out of supply of the medication, and which may cause the people to be less motivating to go to the doctor for the medication. And also when there's less of it, like people have to go buy themselves from private, and which they may have to pay a lot of more money, which they may not have. And also, I found that because a lot of the women are not going to the doctor when they're pregnant, which can be an issue for them to receive the IPTP, which can be an issue for them to receive the IPTP. Because when you're pregnant, that's when it's best for you to prevent it. And so, yeah. And another thing that I found was that a lot of the workers, the medical staff, are not educated on how to provide the IPTP, which can be an issue. And the thing that I think they should do is I feel like they should have a program center where they provide training to medical staff, and also to medical staff, and to make sure that they are knowledgeable on the medication. And also they should educate the woman if the provider are not providing them with the medication, that they should ask for it, which I feel is really important.
Awesome. Well, that is our plan and strategy on resolving this issue around pregnant women that are contracting malaria in Uganda. So thank you for watching.
Thank you so much. All right.
Sweet. Okay, I think we did it for real.
All right. Thanks so much, Brett.
Thanks. Okay, talk to you later.
Bye.
Okay, bye.